So we are so excited to launch the first webinar in our Immigrant Health Education webinar series during this 2025-26 academic year. So today's webinar is titled Understanding Public Benefits Reforms and Medical Repatriation Policies in Philadelphia. My name is Carolina Villamil-Grest. I am an assistant professor in the School of Social Work in Temple University's Barnett College of Public Health. Today, I'll serve as the webinar moderator. So through generous support from Temple University Provost Office Strategic Fund Initiative, the School of Pharmacy, and the Barnett College of Public Health, we've been working in partnership with the Community Advisory Board of Philadelphia-based organizations working with immigrants and underserved communities. You can see here everyone who serves on our advisory board and the organizations that they're affiliated with. This webinar has been co-designed with and presented by our community partners with the shared goal to improve healthcare providers and trainees' understanding of the rapidly changing landscape of public benefits, such as SNAP and medical assistance, for the most vulnerable immigrant and underserved populations in North Philadelphia. If you have any questions, please be sure to enter them into the Q&A function of your Zoom portal and not the chat. The chat is reserved for messages you may have for the webinar host and panelists. We've reserved time for both presentations during a Q&A period after both presenters talk about their work. And then finally, this webinar will be recorded and the recording and webinar materials will be made available to all webinar registrants. Can you advance the slides, please? We also wanted to take an opportunity to thank some of our partners who have made this webinar possible. Again, the Temple University Office of the Provost, Kim Wing, who has helped with many logistics to be able to offer this webinar in an organized way, and then our internal partners from the Temple University Health and Wellness team. So before we begin, let me introduce our two expert presenters for today. I'm delighted to welcome them both. So first we have Andrew Yang, who is a supervising attorney in the Health and Independence Unit at Community Legal Services, a medical legal partnership attorney. His focus is on assisting clients with income supports and public benefits. He supervises MLP or medical legal partnership sites at PHMC, Rising Sun, and CHOP Primary Care South Philadelphia. Mr. Yang was a legal intern and the Temple Legal Aid Clinic here at Temple University, where he represented clients in their disability claims. He was also a legal intern at the Pennsylvania Human Relations Commission and the First Judicial District of the Pennsylvania Court of Common Pleas. During his time in law school, he was a recipient of the James Peter and Stella Licorius Memorial Scholarship and a member of the Rubin Public Interest Law Honor Society. He graduated from Temple Law in 2014 and went on to become an associate attorney representing disabled clients at Martin Law and became the head of Martin Law's Social Security Disability Department. He received the Super Lawyers Rising Stars distinction from 2021 to 2023. Mr. Yang is also a co-founder of the South Philadelphia Participatory Defense Hub, as well as a member of the Up Against the Law legal collective, specializing in supporting activists and community members in their First and Fourth Amendment rights. And David Bennion is a practicing immigration attorney and the executive director of the Free Migration Project. Prior to founding Free Migration Project in 2016, David worked as a staff attorney at nonprofit legal services organizations in both Brooklyn and Philadelphia, and later managed a solo immigration law practice. David graduated from New York University School of Law in 2004. So let's now turn to our first presentation. Andrew will walk us through the recent changes in immigrant access to public benefits and what these mean for our communities.
Great, thank you so much for that and for inviting me to talk about this. I've got a lot of material to move through, so I'll try to move pretty quickly. So What I'll be talking about is immigrant access to benefits and navigating these recent changes. I'll be focusing, um, you know what? Let's go to the next slide there. So I'll be talking about what HR 1 is. That is the budget reconciliation bill. I'll be talking about, I'll go over some immigration terms. I'll go over SNAP cuts as well as cuts to healthcare, and I'll briefly address issues around privacy concerns. Okay, so next slide, HR 1. HR 1 was passed in early July through the budget reconciliation process. It contained the largest cuts to Medicaid and SNAP in history, over $900 billion in cuts to Medicaid and $300 billion in cuts to SNAP benefits. So both Medicaid and SNAP, health insurance and food stamps, are vital programs that Pennsylvanians rely on. About 3 million Pennsylvanians rely on Medicaid to access health care. 2 million Pennsylvanians rely on SNAP to access food. And one of the big changes that HR 1 brought was basically limiting the immigrant categories that are now eligible to receive benefits. So if we could go to the next slide. As a brief review of some of these immigrant categories that I'll be using today, I'll be talking about lawful permanent residents, or LPRs, or green card holders. These are non-citizens who've been granted authorization to live and work in the United States as a permanent basis. There are different ways that you can become an LPR. You can come into the country through some other kind of status, for example, refugee, asylee, T visa, special immigrant from Iraq or Afghanistan, or special immigrant juvenile, and then later get your permanent residency. They're also known as green card holders. Permanent residents, lawful permanent residents, green card holders are one of the few remaining categories that are eligible for public benefits, as you'll see when I continue through this presentation. I'll also be talking about, thank you, refugees and asylees. Refugees are individuals that leave their country because they fear for their own life or safety, or that of their family, when the government will not or cannot protect them from human rights abuses. They enter the U.S. with refugee status, so they've already obtained refugee status when they enter the United States. They become eligible for lawful permanent residency after 1 year as a refugee in the U.S. That's in contrast to asylees, who arrive in the U.S. and then submit claims for refugee status after entering the U.S. And they become asylees if their claims are accepted. They are also eligible for lawful permanent residency after 1 year as an asylee. I'll also be talking about Cuban Haitian entrants, another category that's been preserved in terms of being able to receive some public benefits still. Cuban Haitian entrant is a national of Cuba or Haiti who either was granted parole, even if that parole is now expired, has a pending asylum application, or is in removal proceedings but doesn't have a final enforceable order of removal. As well as VAWA self-petitioners, which are individuals who've been granted permission under the Violence Against Women Act, VAWA, to apply for lawful permanent residency separately from their abusive family member. Okay, so I talked about LPRs, permanent residents, refugees and asylees, Cuban Haitian entrants, and VAWA self-petitioners. And this last slide talks about how immigrant families are usually made up of individuals with different statuses. For a very basic, broad example, undocumented parents might have a U.S. citizen child. So when determining eligibility for public benefits, we look at each individual's status, and we take the household into consideration, and there are also privacy considerations, which also I'll touch upon. All right. So first, I'll talk about changes to SNAP. When we talked about having this presentation, we were initially focused on healthcare, but we agreed that food and food access are such an important part of healthcare, and the SNAP changes are such a big part of the changes to HR 1 that we should probably address that. So I'll start with that. SNAP is food stamps. So a background on SNAP, it goes to people either living alone or groups of people who live together and purchase and prepare, I should say, food together. So that's considered a SNAP household. Kids under 22 must be part of their parents' SNAP household if they live with their parents. There's a 200% federal poverty income limit, but there's no asset limit for SNAP benefits for food stamps. And SNAP grant amounts are dependent on the household size, income, and certain expenses, particularly shelter and childcare expenses. So there's a kind of complex calculation that includes all those factors in terms of determining how much somebody might receive in terms of SNAP. So current eligibility for SNAP includes all of these categories: humanitarian immigrants and qualified immigrants. I'm not going to hang out on this slide for too long because this is changing very quickly. This is going to be changing in November. So we've got about a little over a week left of this current way of doing things before the changes that HR 1 will bring about are going to go into effect. So as you can see, ordinarily, and as of right now, this present moment on October 23rd of 2025, um, a broad range of lawfully present immigrants are eligible for SNAP, including refugees, including asylees, including a number of these other categories, including qualified immigrants that include permanent residents. The changes will severely restrict the categories, and that's that next slide. So HR 1 changes immigrant eligibility for SNAP by taking away food assistance from non-citizens who've historically been eligible. Under the new federal law, the only immigrant groups eligible for SNAP will be green card holders, Cuban Haitian entrants, and what we call COFA migrants, citizens of Micronesia, Palau, or the Marshall Islands. Not all that relevant to us here on the East Coast. So those are the categories of people of immigrants that will be eligible for SNAP along with U.S. citizens. So the next slide, I've got kind of a comparison there. I've got that big green box which showed everybody who's currently eligible, and that red box is everybody who will be eligible as of November 1st of 2025. Now, you'll see, right, with this chart, I hope it's not too confusing. Theoretically speaking, as I said earlier, refugees, asylees, T visa holders, special immigrants, and VAWA petitioners can become lawful permanent residents. And if they do so, then they can receive SNAP benefits. But otherwise, they're not eligible for SNAP benefits. Meanwhile, those who don't have a pathway to permanent residency, like people who have a withholding of removal or parolees, will not be eligible for SNAP benefits. And I should probably say that undocumented folks have never been eligible for SNAP benefits, so that won't change. All right, so next is a timeline. So as it says here, new applicants for SNAP will be subject to the new immigrant eligibility rules starting November 1st. And many immigrants currently receiving SNAP will no longer be eligible under the new rules. So we don't exactly know how they're going to implement a review of current SNAP recipients and start taking people off of SNAP. We're awaiting further, more detailed information. It says there by September 30th. I think what's happening at this point is that, if I'm remembering correctly, immigrant status is reviewed at the SNAP renewal process. So theoretically speaking, somebody could apply for SNAP today, continue to receive SNAP until their next renewal, and continue to get food stamps in that whole interim period of time. So if you know anybody who might be eligible, any immigrants who might be eligible for SNAP benefits, don't wait on applying. They have basically a week to do it, and they can remain on SNAP for a certain period of time after that. And that's kind of what that next slide is about in terms of spreading the word. So we advise that people take actions to protect their benefits. If people have green cards, make sure the county assistance office is aware of the fact that they have green cards. Some people, when they first started receiving SNAP, for instance, the county assistance office knows that they're a refugee or asylee, but were never informed that they later became a permanent resident. And the county assistance office is not always great at keeping track of people's immigration statuses. So we advise that people follow up and make sure they're aware of that. We advise that people watch for letters or notices from the county assistance office that are asking about the immigration status and that they respond to them quickly. If people's food stamps are cut off, and this is true for in any situation, we advise that they file an appeal immediately, because they can at least continue to receive benefits in the meantime. And also, we expect that the county assistance office will probably make mistakes. It always happens when there's bureaucratic change, and cut off some people who should actually be eligible. In addition to that, there are also a number SNAP work requirements are also coming back, which should be the subject of its own kind of training. The bottom line is that for a lot of people, in order to keep their SNAP benefits, they're also going to have to work a certain number of hours or receive a certain amount of pay per week. But there are certain people that are exempt from that. So for more information, you can go to CLS's website. You can go to that next slide to see some of these changes. And we also have other materials about the work exemptions that I've been talking about. And I think Gal put that in the chat, which I appreciate. Okay, I'm going to be talking about changes to healthcare access. I'll particularly talk about Medicaid. And so I might speed through the other stuff because a lot of the folks that we help in the city of Philadelphia, as people in the helping professions, depend primarily on Medicaid. So I'll talk about Medicaid mainly. So Medicaid eligibility changes. Okay, so Medicaid, as many of you may know, is health insurance that's administered by the state, and a lot of it is federally funded. In order to be eligible for Medicaid, there are income and asset limitations or requirements. There may be some disability requirements, and of course, it can be dependent on your immigration status. So currently, the following immigrants can get federally funded non-emergency Medicaid. Anybody who's lawfully, which include that number one is anybody who's lawfully present, which is a very, very broad term that includes basically anybody who's in the U.S. with permission. It also includes humanitarian immigrants. That includes refugees, asylees, Cuban Haitian entrants, human trafficking victims, C visa holders, those with withholding of removal, special immigrants from Iraq or Afghanistan, as well as Afghani and Ukrainian parolees with that time-bound limitation there in that last bullet. Another category, that's the next slide, qualified immigrants who include legal permanent residents, VAWA petitioners, and parolees who've been here for a year, who've had a qualified status for more than 5 years or exempt from the 5-year bar. Basically, the 5-year bar is a rule that says that permanent residents typically can't access public benefits within the first 5 years of their permanent residency unless they meet some kind of exception. So that's those are the exemptions there at the bottom. Okay, next slide. So there are going to be no Medicaid or CHIP changes for kids who are under 21 or pregnant adults. These individuals will continue to be eligible for Medicaid. However, for other adults, for other non-pregnant adults, there are changes coming, and that's that next slide. These changes might sound familiar because once again, it's cutting down this big column on the left of people in that lawfully present bucket into just kind of these very limited categories on the right. That includes, again, green card holders, Cuban Haitian entrants, and COFA migrants. And specifically, that's green card holders who have either been here for more than 5 years or are otherwise exempt from the 5-year bar. And I think I've got a little blue pop-up. Is it going to come up? There we go. That talks about what exactly the 5-year bar is in plain language. But as you can see, it's similar to the SNAP limitations. So once again, this will kick in October of 2026, open enrollment of next year. So currently, folks, a broad range of immigrants are eligible for Medicaid, but this is going to change in October of next year. And if you see this next slide, once again, it's similar to that SNAP chart there. That charts how certain categories can become permanent residents, but otherwise will not have access to Medicaid if they don't get permanent residency by October of 2026. So even for those who retain Medicaid access, there are going to be additional work requirements and new bureaucracy. Those work requirements will kick in January of 2027. We don't exactly know how this is going to be implemented in Pennsylvania. We know there are probably going to be some exceptions, rather some exemptions. And we know that there will probably be additional Medicaid renewals that will occur at least twice a year, whereas they're currently once a year. And anytime, again, there's any kind of bureaucratic change, it means it's harder for people to stay on Medicaid, and people get kicked off when they otherwise should be kept on just because of missing paperwork either on their part or the part of the county assistance office, or confusion about paperwork. All of this is to come, and we're kind of getting ready for it. I'm going to touch very briefly upon the next few slides about Pennie eligibility changes. I'm not going to go in depth here, but Pennie is Pennsylvania's healthcare marketplace. Basically, the way that the health plans on Pennie are made affordable is through premium tax credits, which are available to just about anybody who's lawfully present. There are going to be certain changes that are coming to premium tax credit. Let's just go to the next slide here. Basically, in terms of these immigrant categories, as of January of 2027, so basically after open enrollment, when the plans that you select during open enrollment of next year kick in January of 2027, these premium tax credits will only be available to, again, green card holders, Cuban Haitian entrants, and COFA migrants. There's also going to be additional verification requirements. So if you go to that next slide, looks familiar. These affordable health plans, these health plans that are typically made more affordable with premium tax credits, will now only be accessible for certain immigrant categories, as well as citizens. And of course, if you've heard of enhanced premium tax credits, that's just those are just a way of referring to tax credits that were further modified by legislation to make health plans even more affordable. This is one of the sticking points of the current government shutdown. If those enhanced premium tax credits aren't renewed, it means that health plans will basically become very expensive for everybody. This is a little bit confusing, so I won't hang out on it too long, but another change is that premium tax credits currently available to all lawfully present immigrants under 100% poverty level will end on January of 2026. It reopens what was a loophole that had been closed by legislation. Bottom line here is that it just makes healthcare even more expensive, particularly for folks who are below 100% poverty level. Okay. Medicare changes are going to look similar. Normally, lawfully present non-citizens can qualify for Medicare if they meet Medicare's other age, disability, and work history requirements. And this is a change that has already started. As of the passage of H.R. 1, all new Medicare applicants needed to have met the new immigrant eligibility requirements. Again, green card holders, Cuban Haitian entrants, COFA migrants. At some point before July 4th of 2026, Social Security is going to review Medicare enrollees and notify them that their Medicare is going to end in July of 2027. And on July 4th of 2027 is supposed to be the date when all current Medicare beneficiaries who don't currently meet the immigration status requirements will be terminated from Medicare. So my next two slides are about options for folks, or about the limited number of options for folks who are going to be removed from Medicaid or their normal health insurance. There is a such thing as state-funded Medicaid, which is the full package of Medicaid benefits available to certain categories of very low income or asset lawfully present adults. So you need to be lawfully present. So you need to be in one of these categories. You need to be in one of these special particular categories. For instance, older than 59, a parent of a kid under 21. You need to be disabled, a caregiver in drug and alcohol rehab, or a victim of domestic violence. And you also need to have a very low amount of income and assets. If you meet all of those three things, you may be eligible for state-funded Medicaid, even if you can't receive federal Medicaid. And the last option is emergency Medicaid, which is available to everyone regardless of immigration status, including undocumented folks. In fact, for undocumented folks, oftentimes this is the only healthcare that's available to them. So this is available to people who meet all Medicaid eligibility criteria, except that they have some kind of immigration status that makes them unable to have regular Medicaid, and who have an emergency medical condition. Medicaid benefits are available for the treatment of that emergency medical condition. Um, so HR1 doesn't change EMA at all. A lot of people were afraid of that. So HR1 doesn't change EMA eligibility. However, it does introduce certain changes regarding federal funding that might make it hard for certain people to access EMA. It depends on what the state does in response to this reduced funding. All right. So similar to what I said about SNAP benefits, if you or somebody that you're trying to help has a green card, make sure the county assistance office is aware of it. If you receive a termination notice, we recommend that people appeal that right away, and CLS can help with those appeals. And also, we remind people that even if you're not eligible under the new rules, other eligible members of the household might be able to continue to get benefits. For example, if you're an asylee who doesn't yet have a green card, who has U.S. citizen children, you can continue to get SNAP and Medicaid for the children, even after HR1's new rules go into effect. Okay, so lastly, and I'll talk about this pretty quick, addressing privacy concerns. If we can go to the next slide, this is the most important thing here, which is that the USDA and Health and Human Services have made recent efforts to collect large amounts of public benefit data from states, and they've shared this bad data with the Department of Homeland Security, who has then shared it with ICE. So there's some litigation to stop this data collection. We used to tell people that it was worth it to apply for public benefits, and I still think that's true. But in addition to that, we're also telling people to consider the risk that the information that they put on a public benefit application could be shared with immigration officials, because that's just how that's the truth. This next slide talks about how this data flows. You can see that it goes from the county assistance office, which goes to PADHS, which is supposed to report to the USDA and HHS, and that's how it, at least in the past recent months, has flowed to uh to ICE, essentially, to the Department of Homeland Security, and then to ICE. So in terms of talking with immigrant families, we remind people that oh yes, and of course there's that thing that says that the county assistance office is permitted to share information in order to verify eligibility. Federal law prohibits the use of this for immigration enforcement purposes, which is what the litigation is about. We think that some of what they're doing with this information is illegal. So in terms of talking with immigrant families, if you receive public benefits or a member of the family receives public benefits, it's a lot of the information in the public benefit record is probably already available to the federal government, and withdrawing from public benefits isn't going to make you more safe. So I've told a lot of my clients this because there's a lot of fear. If they're already getting public benefits, stopping those benefits is not going to stop immigration enforcement. Similarly, the next slide, if the Department of Homeland Security already has your address, if you have a pending asylum application, for instance, applying for public benefits isn't going to put you at any additional risk. Um, and the next slide, if you're applying for public benefits for certain members of your household, you're not required to provide Social Security numbers or immigration status for individuals of the household who aren't seeking benefits for themselves, and you shouldn't do so. For instance, if an undocumented mother is applying for Medicaid for her kids, happens a lot, she doesn't need to answer immigration questions about her own immigration status. She doesn't need to answer Social Security questions for herself. She's legally allowed to just put in information for the people who are trying to get the benefits, her children. So lastly, public benefit programs can be very helpful and important. They're a lifeline for a lot of people. So we encourage people to consider their own risk and balance the value of receiving these public benefits with the risk of sharing information. Only you can decide what's best for you and your family. It's something that I tell my clients a lot. All right, and I made it in 30 minutes. Do I throw it over to Carolina?
Yes,
Great.
yes, Andrew, thank you so much. That was an excellently comprehensive overview. Just as a quick reminder, we're going to move on to our second presentation, but before we do, I just wanted to remind everybody to place their questions into the Q&A box, and we will have a period of questions and answers after the next presentation. So I'd like to invite David Bennion to share his work.
Thank you, everyone, and thank you, Andrew, for that informative presentation, for all the work that you do on these issues. It's very much appreciated and needed. Um, my name is David Bennion. I'm Executive Director at Free Migration Project. We have a small office in Kensington and Philadelphia. We provide legal services to undocumented folks and their families. We work on immigrant rights campaigns, and we generally advocate for freedom of movement as a basic human right. We try to work at the intersection of law and community organizing, and we envision a world where free movement of people is the legal, social, and cultural norm. We call for the abolition of all deportation. Um, so about 5 years ago, a few months into the pandemic, we got a call from a social worker who was in contact with a family from Guatemala, and the person she was in contact with, her uncle, was currently a patient at Jefferson Torresdale Hospital in Northeast Philadelphia, and the hospital was planning to put him on a charter flight to Guatemala. In I think about 36 hours, we got notice. He had been seriously injured after he was hit as a pedestrian by a motorcycle on Roosevelt Boulevard, and the hospital had treated him for a period of time, um, stabilized his condition to an extent, um, and then realized that he might not qualify for um, emergency federally funded care going forward, and they didn't want to be, as they saw it, saddled with a long-term patient who wasn't going to have their care funded through other sources. Um, they did some very cursory questioning of the niece as to what the patient's immigration status was, and then again made an ill-informed decision to pay the medical transport company. We don't know exactly how much. Generally, costs can run around $50,000 to avoid what they saw as potentially being a larger long-term cost to forcibly remove the patient from the hospital and from the United States. Um, they were doing this despite federal law around discharge under EMTALA. I know the acronym, I can't recall what it stands for, but essentially the federal rules around discharge have a lot of gaps, and really in many cases enable or facilitate this sort of practice from hospitals. And the idea being, well, it's not an improper discharge if it's just a transfer. We're just transferring the patient to their country of origin to receive whatever care they need there. Well, maybe that's fine if you are sending someone to Canada or Germany or somewhere where the patient can actually anticipate receiving the care that they need, and that transfer will actually be in their medical best interest. Most of these cases, that's not the case. There was no such care available in Guatemala, and the family definitely did not give their consent, and the patient um, was, I believe, comatose at that time and also on a breathing tube. And so the family believed that he would have died in the course of that transportation. The best case scenario would have been essentially that he could make it to Guatemala alive, but then the medical transport company we believe would just dump him wherever they felt that they needed to. Maybe that would be at a hospital's doorstep, maybe it would be at the airport. Nobody really knows. This is a practice that's not regulated anywhere in the United States specifically, except for now Philadelphia, and I'll talk about that a little bit more in a minute. So when we're talking about medical deportation, you know, this was something I had heard about years ago, but didn't know much about. And I think that's the case for most folks who either work in immigrant health or in immigration law. And the fact that it touches on both those fields is very confusing to, I would say, most people, most care workers or professionals. Um, and so, we've uh, had to learn a lot about the healthcare system and the health insurance system. And we've also tried to engage with people in that field to inform them about this practice and also about the immigration law aspects of the practice, since that's our area of primary expertise. Um, what we're talking about is the removal by uh, typically hospitals, so not the federal government, of an uninsured or underinsured immigrant patient, typically undocumented, but not always, who has been seriously injured or is ill, from the United States to another country without the informed consent of the patient or their caretaker. Next slide, please. So the photo on the left is actual photo of AV, who is the individual that I mentioned. With his case and with the other individual pictured, who is SC, we've taken some measures to protect their identity, but their families, and then at a certain point, to the extent that they were able, the patients themselves, um, felt that this was an unjust practice and that they didn't want anyone else to have to go through this. So they've been quite public about their cases and their efforts to combat medical deportation for their families and also for other similarly situated people. Um, and so SC is a woman, a mother and wife from the Dominican Republic who was living in Allentown, Pennsylvania, with her husband and their two sons, and in late 2022 suffered a stroke after a ruptured aneurysm um, in the course of treatment at a hospital in Allentown. The hospital was very motivated to deport her. Fortunately, Free Migration Project, in collaboration with folks at Community Legal Services, PIC, the Pennsylvania Immigration Coalition, and others, were able to mobilize in both these cases to essentially show up in person at the hospitals and call the media, call policymakers on city council and other, and just sort of make a lot of noise to create enough space for the hospital just to stop or slow down on their plan to forcibly remove somebody from the US until an alternative plan could be reached. Uh, Typically, so far it's been through EMA, emergency medical assistance, and then arranging for transfer to skilled nursing facilities where the EMA will cover care there. And so it's kind of on the one hand, in these cases, quite confrontational, and community-oriented, community-based approach that didn't honestly have that much to do with law or health coverage. It had to do with optics and uh, morality and what the community was willing to do to show up in support of families. And then, but then there had to be a pivot to the sort of longer term, more behind the scenes effort to arrange for ongoing care and health coverage. And really, that's where folks at CLS have been essential in educating us and others and the families on what the options for coverage are, and walking with the families through the process. And fortunately, both individuals have recovered to varying extents. Both will still experience lifelong disability and probably chronic health issues. But they've been able to be with their families. They were able to be to reach a point where they can more reasonably recuperate rather than potentially, uh, facing catastrophic health consequences or even death due to a premature repatriation that nobody said they wanted to do. Next slide, please. So, in the course of AV's case, we were able to coordinate with other organizations, with the students at the Penn Law School, with students at Temple Law School, um, with the folks at the UPenn Law School Legislative Clinic. We co-authored a report in 2021 about medical deportation. Kind of what are some of the causes? What does the practice look like? What are some things that people can do to prevent it? We created a hotline for folks to report instances of potential medical deportation, and so that we can engage and try to share information and resources, and in a small number of cases, maybe engage in more coordinated action to stop a medical deportation. Thanks for sharing the link there. The report is on our website, and it's a good resource for folks who want to learn more about medical deportation. Um, Next slide, please. So at the end of 2023, we saw the culmination of about a 2-year process where we started working with the uh, law students at the Temple Scheller Center for Social Justice under Professor Lee. Under her guidance, the students really worked hard to draft a city ordinance based on what we knew about medical deportation at the time, to make Philadelphia the first jurisdiction in the country, state, federal, or local, to have any law regulating this practice. And it passed. It passed by a good margin, 14-1. Um, and we're hopeful that that law can be a template for potentially other jurisdictions elsewhere, anywhere around the country, or even elsewhere. And we hope to, as an organization and a campaign, serve as a resource for others who are trying to educate the community about medical deportation, or even try to pass laws to regulate. Next slide, please. So it's a bit of a light touch given that it's a local ordinance. It doesn't explicitly ban the practice outright, but it does set up certain requirements for hospitals in Philadelphia, because Philadelphia has its own home charter, has a little bit more legislative autonomy than many other places in the Commonwealth. So the ordinance says hospitals have to actually get informed consent from their patients and document it with language access for non-English speaking patients or their families before they transport a patient to another country, and they have to, get this in writing. They have to report information about specific cases privately to the city health department. They have to publicly report aggregated anonymous data to the city council. And then the city, through the health department, can investigate violations, issue fines, and it also creates a private right of action for, I use the term citizens there. That's not actually accurate. It's anyone who might be impacted, to sue the hospitals directly for violations. Next slide, please. Um, so yeah, yeah, either slide, this slide or the other one with our socials is fine. If folks want to follow us for more updates, or download the report, or take down the hotline number in case you hear of the possibility of a coercive repatriation is one way to say it, or medical deportation, sort of more colloquially. We'd be happy to talk to folks, to share resources, even to do other informational presentations if it's helpful. And I'll stop there for now. Thank you.
Excellent. Thank you, David, for that super informative presentation and for this excellent advocacy work. So now we're going to move on to the questions and answers. So I see we have two questions in the Q&A box that we can start with. First, for Andrew, it's always been very unclear whether folks with pending asylum applications, such as Social Security numbers, EADs, are eligible for public benefits. What does your office say?
Right. So generally, pending asylum applicants, even those with Social Security numbers, are not eligible for SNAP or Medicaid. One of the disappointing things about HR1 is that we used to tell people one of the reasons that having asylum status was so important was because it was a way of getting public benefits, and people would wait for a very long time in order to get asylum granted. And at this point, we're telling roomfuls of immigrants and of refugees and asylees that even if you do have that status, you will not have access to public benefits, which is an incredible shock to a lot of people, especially since that's been kind of the golden ticket for them for so long. So, bottom line, pending asylum seekers typically don't have access to public benefits, and unfortunately, asylees will not either.
Great, thank you. Okay, so there's one more question in the Q&A that I'll read aloud. I have also received conflicting advice from attorneys regarding the public benefits and the now defunct public charge rule. If you have time, can you speak on that?
Yes. So, the public charge test is so public charge is a mechanism by which that is contained in the law, where they tried to determine whether somebody is at risk of becoming a public charge. Basically, the bottom line here, it used to be more of a concern, particularly in the last Trump administration, where the concern was that seeking certain public benefits would make it difficult for you for your immigration application. Um, First of all, the rule of public charge only applies to certain categories. If you're considering, if you're considering getting a permanent residency that is a green card, or you're an applicant for a visa or certain types of visa or visa renewals, those are the only circumstances where things like public charge are uh, are assessed. So it doesn't apply to refugees or asylees. It doesn't apply to, VAWA applicants. It doesn't apply to U.S. citizens. If you already have your permanent residency, if you already have a visa, it doesn't matter. Also, even today, USCIS is supposed to use the totality of circumstances approach to determine whether to grant permanent residency or a visa. So one thing alone, like receiving a public benefit, is not supposed to sink an entire application, and a competent immigration attorney will tell you about certain ways to mitigate, if it is even a bad factor on your application, to mitigate that. So a lot of people are afraid of the rule, but it only applies in a narrow set of circumstances, and even when it applies, it's not a it's it doesn't it's not the end of the world. It's not the end of the application.
Thank you for that clarification. So we have a couple questions. One for both of you. What role can healthcare providers, social workers, or advocates play in preventing unjust medical repatriation? Actually, it's for David.
Sure. I think maybe the first thing would be to um, become informed about what it is and how it works. And hopefully the presentation today has been a step towards that. Just because 9 times out of 10, it's hard for people to understand what's actually happening, partly because we're dealing with multiple sort of complex legal systems and bureaucracies. And a lot of the time I've seen that health professionals or health workers tend to sort of shut off their brain to an extent when it comes to immigration law. And then for immigration specialists, it's the same for health law and benefits. It's just like, oh, well, that's something confusing that I don't understand. And so in that sort of confusion or that gap between the two spaces, hospitals can jump right in and sort of mislead patients or their families. Hospital social workers, unfortunately, we've seen some great ones who really are advocating on behalf of the patients, but we've seen others who are really advocating on behalf of the hospitals and are providing patients or their families with misleading or just flatly untrue information. And they see their role really as to facilitate what's in the financial interests of the hospital. And unfortunately, any discharge, as I understand it, has to be signed off by a doctor. And we've seen multiple cases where the proposed discharge plan is not in the medical interest of the patient, and yet the hospital can come up with a doctor to sign off on it anyway. So, it depends kind of what folks' role and position is as to how they might encounter a potential medical deportation. But knowing a little bit more about what it is and at the end of the day, it's quite simple. If the hospital is saying we want to discharge a patient to another country and that's not going to be in their best interest, and the patient and their family don't want to do that, then what you're looking at is a potential medical deportation. And there's no sort of silver bullet to stop it from happening. Usually it's a combination of different factors, but at the end of the day, standing up to the hospital on behalf of the patient is the key thing.
Thank you. Yeah, that's a really helpful, it's really helpful guidance. Thank you. So we have one more question in the Q&A, and I actually, before I jump to that, I wanted to ask one question for the both of you. How can participants use what they learned today to advocate for more equitable healthcare practices in their own institutions? I know, David, you provided a really helpful, case example just with the entire arc of medical repatriation policies. It's just an excellent case example. And from what I gleaned from your response is just really interdisciplinary advocacy, really across the board within institutions. But I wonder if there's any other insights that either of you have, gained from your work.
Yeah, I mean, we could be talking about a range of different institutions, I imagine, or organizational settings, and so it's really contextual on
Yeah.
what what's the what are the objectives of the organization, who are the constituents or the community that they serve. In general, it should ideally be everyone working together to promote, better health for immigrant communities. Unfortunately, that's not exactly how the health system is set up, and certainly not the immigration legal system. Um, so, it's just good to just do a very simple gut check and say, is my organization and my role in this particular instance, is it helping somebody find a pathway to better health, or is it helping defend an institution or a hospital's bottom line? This is a very specific niche issue, and I know there are many broader issues touching on immigrant health. But the consequences of medical deportation can be very severe, and so we think it's important for people to know about.
Thank you for that. I'm assuming, Andrew, you're not muted. I don't know if
Oh, no, I'm not. Yeah, I'll answer that briefly. As a medical legal partnership attorney, y- I think the way I would answer that question is to remember that uh, health is holistic, and there are social factors that determine that go into whether somebody's healthy or not. One of the things I love about being a medical legal partnership attorney is that I can depend on the expertise of doctors and social workers, and all of us are working together to improve somebody's health. That the law affects their health, just like germs affect their health, just like the condition of their house affects their health. It all affects health, and it's bigger than any one of our fields, and we're working together to help these people. And I'm reluctant to to tell to say that as like prescriptive advice, because I'm honestly I feel like so many doctors and health professionals and social workers understand these things better than attorneys do, better than I do. So I'm always learning from them and being reminded by them that this is the case.
Great, thank you for that. Before we close, there is one more question that directed to Andrew. I think it could be quickly answered. Can the work requirement for SNAP be fulfilled by volunteer work, Andrew?
Yes, absolutely. And that's a great question. I could talk for another hour about work exemptions, but I want to highlight two exemptions to SNAP work, including this volunteer one. So in order to be exempt from the work requirement, you can be volunteering. And in order to do that, you would probably submit a form called the PA 1938. So we're getting a little bit into the weeds here. But while I'm on the subject of forms, I also want to highlight another form that is probably relevant to people as medical professionals, which is the PA 1921, and that's the medical exemption form. So if you have any kind of health condition that affects your ability to work, and you can get any kind of not just doctor, but basically anybody that works at a medical office to sign off on this form, the 1921, you can be exempt from the work requirements. So obviously that's important for SNAP recipients, but it's also important for those of you who are in, health settings. When you see this form, the PA 1921, it's an opportunity for you to help people out. That, obviously it's a very broad term. Any kind of medical condition that affects your ability to work, that's very broad. And we encourage professionals to interpret that broadly because it should be interpreted broadly.
Great, Andrew. I think we just stumbled upon another topic area of discussion for a future webinar. And thanks to all participants for these thoughtful questions and your engagement today. As we wrap up, just a few final announcements. Please stay tuned for some upcoming webinars. The next topic area focuses on social services and navigation training that we're planning to be held on at the end of January 2026. We'll send this information to you all in a follow-up email. This webinar is being recorded, and the recording and webinar materials will be made available in a follow-up email as well to all webinar registrants. And lastly, we'll be sending a Qualtrics survey to those who registered, requesting your feedback. Please find the link to the survey in the chat and stay tuned for a follow-up email with the survey link and, as I mentioned, the materials. Thank you all again to everyone involved in this effort and to registrants and participants for your interest and participation. Have a great afternoon.